Hi, I'm Allison Fauner, and I'm a scientific data curator at PharmGKB. Today I'm going to be talking about the pharmacogenomics of drug transporters. So I'm going to start with giving you a little overview about what drug transporters are, how they work, and where you find them, and their role in pharmacokinetics and pharmacodynamics. Then I'll tell you a little bit about genetic variation in the genes that encode drug transporters and how that affects the pharmacokinetics and pharmacodynamics of the systems. To illustrate this a little better, I have two examples. One is genetic variation in the gene SLC01B1 and its impact on statins, so statin treatment, and its impact on circulating statin levels and risk of adverse events. I'll also talk about genetic variation in ABCB1 and that's impact on the PGP protein, P glycoprotein, and how that affects chemotherapy and immune suppression after organ transplants. So my goal is that by the end of this session, you'll understand about what drug transporters are and how they work, and see how genetic variation can affect systemic exposure to drugs and impact on efficacy and risk of adverse side effects. So starting with a reminder of pharmacokinetics and pharmacodynamics. Remember the four principles: absorption, distribution, metabolism, and excretion. And remember, when you take a drug by an oral dose, as it passes through the intestine, it will be absorbed into the gut. And from the gut, it passes into the portal vein, which travels directly to the liver. In the liver, some of this drug will be taken up by the liver and metabolized for first pass metabolism. Anything that's left or anything that returns to the bloodstream will enter circulation and be delivered to the target tissues, where it again must be removed from the bloodstream into target tissues. Following this event, anything in the blood returns back to the liver, where it will undergo metabolism and excretion. So small lipophilic compounds can diffuse right through the membrane, but polar or large compounds cannot. And you'll see in this figure that in all of the transitions between extracellular and intracellular positions, there are these proteins, and those are the drug transporters. So drug transporters are proteins that are bound in the cell membranes, and they are in contact with both the intracellular and the extracellular materials, and so they can bind these large polar compounds on one side of the membrane, and through conformational changes, transfer that compound to the other side of the membrane. And there are two ways that works. One is through influx, which is uptake into the cells, so taking a compound that's on the outside of a cell and moving it to the inside of a cell. The other way they can work is through efflux, which is the opposite, taking something that's inside of a cell and moving it to the outside of a cell. There are two main superfamilies of drug transporters. They're classified based on their function, and they're named based on their structural similarities. So the first type are the ATP binding cassettes, or the ABC proteins. And these are mostly involved in export. So they are primary active transporters, which means that they have to bind and metabolize ATP to move a compound from the inside of a cell to the outside of a cell. The other type are solute carrier proteins, SLC. And those are involved in uptake, so moving things from the outside of a cell to the inside of a cell. And those work through secondary active transport, which means by coupling with the movement of an ion through the cell membrane, they can also move these compounds. So this image shows different important barriers in the body. So we have the intestine, hepatocytes in the liver, in the kidney, and then also the blood-brain barrier. And this figure shows that at each of the transition points between these organs and the blood, you have these transporters, which are the blue and the red circles. And you'll see by the direction of the arrows that some of these transporters work in influx and some work in efflux. And the the composition of which transporters are where determines what compounds can get in or out of a cell at different amounts. So how does genetic variation affect this? Like any other protein, genetic variation in the gene that encodes the protein can affect how much of a transporter is present and how well it works. So in terms of how much of a transporter, we can have changes in DNA that affect how much of the transporter is produced to begin with. So whether there's a change that creates a stop codon in early truncation of a protein, or it can create a protein that's unstable and that's degraded very quickly so that the transporter can't accumulate in the membrane. Another way this works is through incorrect localization. So because the protein has to find its way into the cell membrane, if it's missing the ability to do that, the transporter won't get to the right place. The other way genetic variation can affect drug transporters is by changing the function. So the amount of a drug transporter won't change, but its ability to work does. And this can happen through changes in the active site of a protein, so its ability to bind the compound that it's trying to move, or its ability to bind any cofactors that it needs, like the ATP. Genetic variation can also affect the ability of a transporter to make the movement from one side of the membrane to the other. So in addition to binding, it also has to be able to change conformations and then release the compound on the other side of the membrane. And these changes can increase function or decrease function, and because of the different roles of drug transporters, can either increase or decrease activity and also affect influx and efflux of compounds in the cells. So as an example of this, I want to talk about the OATP1B1 transporter, which is encoded by the SLC01B1 gene. And this affects statin response and circulating levels of statins. Specifically, simvastatin is what I'll be talking about today. So as you may know, statins inhibit cholesterol production, and they're used to treat high cholesterol. More than 25% of Americans over the age of 45 use a statin, and it's one of the most commonly prescribed drugs. However, the adverse side effects related to statin therapy are muscle degradation with pain, which is myopathy, and this is caused by high concentrations of the drug in circulation. So it's important to remember as we go through this that there are many types of statins, and each one, because of its slightly different chemistry and structure, interacts a little bit differently with these drug transporters and has different PK properties. So this is an image from the PharmGKB website, which shows statin as it travels through the body. So you'll see statin in the upper left, which is a purple rectangle, and these light blue ovals are transporters with the name of the transporter written inside, and then these purple rectangles with the yellow are any metabolites that are produced, and the dark blue ovals are metabolizing enzymes. The beige shapes are different cell types. So you'll see that statin is taken as an oral dose. It's moved into the intestinal epithelial cells by transporters, and it enters the bloodstream. And then the key thing we want to talk about here is the uptake from the bloodstream into the hepatocytes, where the statin undergoes metabolism and then is excreted. So this SLC01B1 gene encodes the organic anion transporting polypeptide 1B1, the OATP1B1 protein. It's an influx transporter. You can see I've circled it in yellow here. And it's expressed on the basolateral membrane of human hepatocytes. So what it does is it mediates the uptake of its substrates from portal blood into the liver for metabolism, and then subsequently clearance into the bile for elimination from the body. Now, variation in the SLCO1B1 gene can affect the function of this transporter. There are a few different haplotypes that are most important in understanding the function of this gene. So the first is the STAR1B haplotype, which is a G at the 388 position. And this results in increased activity of the OATP1B1 transporter. The second haplotype is the STAR5 haplotype, which is a C allele at the 521 position. And it results in reduced activity of OATP1B1. And then the third haplotype is the STAR15, which is both a C allele at the 521 position and a G allele at the 388 position. And this also results in reduced activity of OATP1B1. So I want you to think about where this transporter is present in the body, so on the surface of the liver, moving things from the bloodstream into the liver for metabolism. And think about the effect that these changes in activity would have on the circulating levels of the substrates for OATP in the bloodstream. So remembering what this transporter does, if you increase the activity of the transporter, you're going to be moving things from the bloodstream into the liver more quickly for metabolism. And as a result, you will have lower plasma concentrations of any of its substrates. The opposite is true if you reduce the activity of the transporter. You'll end up with increased plasma concentrations of any substrates. So you'll see that the STAR1B haplotype results in increased activity of the transporter and lower plasma concentrations of any of the substrates, including simvastatin. The STAR5 and the STAR15 haplotypes result in reduced activity of the transporter and result in increased plasma concentrations of simvastatin. So how do we see this in activity? So the main position to think about here is that 521 position. That change from a T to a C is present in the region of the protein that is membrane bound. And remember that high statin concentrations increase risk of myopathy, which is muscle pain and weakness. And we want to avoid that if we can in treating our patients. So individuals with this 521C allele have a reduced transporter function, and as a result, have reduced statin uptake into hepatic cells. What you'll see on these graphs on the right side of this screen is that, consistent with what we're saying here, individuals with 2 copies of the CC allele have lower uptake of simvastatin into the liver, and as a result, have higher circulating levels of simvastatin in the bloodstream. And as you'll see below that, because high circulating levels of simvastatin are associated with increased risk of myopathy, you'll see that individuals with the CC haplotype have higher rates of myopathy compared to individuals who have either TC or TC or TT at that 521 position. And like we mentioned earlier, different statins have different properties. So you can see here this plot on the left. We have individuals with either 0 copies of the STAR5 haplotype or 1 or more copies. And as we showed on the previous slide, individuals with these alleles end up with higher circulating concentrations of simvastatin. And you can see that this bar plot shows the percent of patients taking this drug who end up with adverse events from taking the drug. So you can see that in simvastatin, there's a much higher percentage of patients with this STAR5 haplotype who have these adverse events related to high statin dose compared to patients who are taking these other types of statins, atorvastatin and pravastatin. Like we mentioned before, these adverse events are related to concentration of the statin in the blood. So you can see simvastatin for individuals who have that C allele at the 521 position have these higher circulating levels of simvastatin in the bloodstream compared to these other statins that maybe are not as good of substrates of the OATP1B1. So how big of a problem is this? If we look at allele frequencies throughout the globe, we can see that the frequency of these low activity star 5 and star 15 haplotypes are quite common, though the frequency changes in different populations globally. We can also see that high activity, the star 1b haplotype, is also very common, especially in sub-Saharan Africans and African Americans. And remember, we want high enough concentrations where the statin actually is able to reduce cholesterol production. And so having a high activity haplotype can be just as bad as having a low activity haplotype in terms of getting the efficacy and the results that we want from using statin treatments. So what can we do about this? There's actually a CPIC guideline that recommends testing for this haplotype at the 521 allele position to determine statin treatment prior to initiating therapy. You'll see in this table that depending on what alleles a person has at that 521 position, we can either change the dose. So with simvastatin, for someone who has 2 copies of the T allele, you would give that person a lot higher of a dose compared to someone who has 2 copies of the C allele. Or we can just change which statin we use to treat these people. So another example that I want to use is the ABCB1 gene, which encodes the P-glycoprotein, or which is also known as the multi-drug resistance protein. Now, different from what we talked about before, this is an ATP-dependent efflux protein, which means its role is to take compounds from inside the cell and remove them from the inside of the cell to the outside of the cell. And this protein has a very broad substrate specificity, which means it can affect response to many different types of drugs. And it is found throughout the body at some very crucial transition points from the bloodstream to organs, or from outside of the body inside the body. So for example, it's found in the intestinal epithelial cells, in the liver, in the blood-brain, and the blood-testes barriers. So what it does is, because of its positions throughout the body, it regulates oral absorption, renal clearance, and penetration into target organs. So like we did with the OATP1B1, I want you to think a little bit about what increased PGP expression would do to these different PK parameters. So this picture on the right shows that the PGP is expressed in intestinal epithelial cells at the interface between the intestine and where it enters the body. And it's also present in the liver, moving things from inside hepatocytes into the bile for excretion. So if we increase PGP expression or function, what would we do to oral bioavailability? What would we do to maximal plasma concentrations? What would happen to hepatic clearance? And then ultimately, what would happen to the area under the curve, which is equivalent to systemic exposure? So, because the PGP moves things from inside intestinal epithelial cells back into the intestine, we would have decreased oral availability, and as a result, would have decreased maximal plasma concentrations because not as much of any substrate enters the bloodstream. We would have increased hepatic clearance because anything that's metabolized or is in the liver will be moved into the bile more quickly. And as a result of having less absorption and more excretion, we will have decreased AUC and decreased systemic exposure. An example of where this matters is in immune suppression after an organ transplant. So one of the drugs that we use is tacrolimus, and this suppresses the immune system so that the patient's immune system doesn't reject an organ. Now at this 3-4-3-5 position, we can have a C allele or a T allele. The C allele results in increased PGP activity, which results in less drug absorption, as you can see in this figure on the right. The T allele results in decreased activity or more absorption. And this is an important consideration because in treating patients who have organ transplants, we want to suppress their immune system to the point where they don't reject an organ, but too high of circulating levels can lead to nephrotoxicity, which is killing kidney cells. But if we have too low of a concentration, then the person is still at risk of rejecting the organ. So it's a very tight window that we have to keep our circulating levels within. Another example of how this works is in cancer cells. So in tumor development, the cells proliferate and new mutations arise with each time that a cell divides in creating the tumor. Now, a lot of drugs that are used in chemotherapies are removed from a cancer cell by this PGP or MDR1 transporter. And if a mutation occurs in one of these cell divisions that increases the activity of the PGP, then more of the chemotherapeutic agents that get into a cell are going to be removed from that cell, and the cell will no longer be killed by the chemotherapy. As a result, the chemotherapy can kill any cells in the tumor that are still sensitive to the drugs, but these tumor cells that have now overexpressed or increased function of the PGP are going to survive, and those are the ones that are going to keep proliferating to create these tumors. And that's what creates tumors that are resistant to some of these chemotherapies and don't respond well to treatment. So at the end of this session, what I hope you got out of this lesson was an understanding of the role of transporters in controlling the absorption, the distribution, the metabolism, and the excretion of drugs, both their role in influx and efflux throughout the system. I also hope you understand how genetic variation can affect transporter activity and the impact that this has on efficacy and toxicities related to drug treatment. To illustrate these points, we use two examples. One is common variation in the SLCO1B1 gene and its impact on simvastatin and statin treatments. And the other is looking at the efflux transporter PGP, which is also known as multi-drug resistance protein, and how variation in the gene that encodes it, the ABCB1, affects both treatment for immune suppression and cancer treatments, among many other therapies. And ultimately, we want to understand how changes in transporter function are important clinically. Thank you.